Rolling right along, here we go. Okay. Again, we're going to sort of try to compartmentalize this a little bit for you to make it clear. We're going to talk about the presentation and management of patients with platelet disorders. We'll talk a little bit about coagulopathy. We'll end with a little bit about thrombophilia. And I think we're going to dive right in with a case. So this is a 3-year-old noted at bath time to have several bruises on her back. The following morning, she had numerous little tiny red spots on the trunk and abdomen. Exam reveals multiple petechiae on the skin, several on her soft palate. Exam otherwise unremarkable. What is her most likely diagnosis? Excellent. Easy one for you right out of the chute. So it sounds like this girl probably has ITP, right? And actually, now that I think about it, again, we keep changing words, changing diagnoses, changing names. I think we're actually morphing to calling this immune thrombocytopenia. So I'm going to have to stop saying that kids have ITP. IT doesn't sound right. But I think generally speaking, most kids don't have purpura. I don't know why we're changing the name, but immune thrombocytopenia at any rate. So let's talk a little bit about that. So the definition is isolated immune-mediated thrombocytopenia. Try as you might, we don't test for, and you will rarely find an antiplatelet antibody in the blood, but it is an immune-mediated process. Peak age is 2 to 5 years. About half of patients are in that age range. Trust me, it can be in any range, infants, school age, teenagers, you name it. Very common. Any busy pediatrician, family practitioner might see at least one of these, if not more, in a year. Often preceded by a viral illness, not always, but of course when you think of the immune system kind of being revved up, dealing with a viral illness, then sometimes there is just this bystander effect and the platelets begin to be destroyed. I've seen a couple of cases as well that seem to happen after immunization. That's really probably more anecdotal than anything. Acute onset, this is usually with skin only, physical exam findings, but certainly may involve mucous membranes, which we do refer to as wet purpura. Sometimes you'll see, inside the cheeks, you'll see it looks like they have little blood blisters on the inside of their cheeks, inside of their lower lip, or upper lip maybe. Microscopic hematuria may be present. Most people who take care of these patients will check for microscopic hematuria. This is an indication to give them some IV fluids until you flush that out. Hepatosplenomegaly or lymphadenopathy should lead you to be exploring something else as a potential diagnosis, in particular acute leukemia. These patients really should have pretty boring physical exams other than the petechiae and bruising that you see. This is a self-limited problem. 80%, possibly more, patients will resolve within 6 months. We try very hard to have a hands-off approach with them. We'll talk a little bit about that. Again, if other cell lines are affected, if they have any leukopenia, neutropenia, anemia, any other abnormalities on the CBC, you really should be thinking about something else, not just immune thrombocytopenia, okay? So how do we work these kids up? Well, a CBC with differential, you want to verify, right, that only their platelets are affected. You would like to verify that they have a normal diff, that you're not thinking about something else. Look for other abnormalities. If they have anemia, if they have leukopenia, neutropenia, like I said, that may suggest an alternate diagnosis. Do you have new leukemia? I really should put ALL or AML. You can't tell just by looking at a CBC. Do they have aplastic anemia? Sometimes when those kids present, they can have platelet counts that are very low, that look very similar to a patient with ITP. Might they have Evans syndrome, which is autoimmune destruction of more than one cell line? So do you have a kid with low platelets? They also have a little bit of a low hemoglobin that looks like they might be hemolyzing, okay? We do test, check their blood type, ABO and RH. This is helpful to know in case we need to give them Big D as their therapy, or Winrow. If there is a possibility that you'll need an urgent need for platelet transfusion in case of dangerous clinical bleeding, as in intracranial hemorrhage, you want to have something ready to go in the blood bank. Of course, look at their peripheral smear, right? So this verifies your automated number, makes sure that it's not erroneous thrombocytopenia, let's say from a clump, in the bottom of the tube when the child was drawn. And you really want to scan around and look for very large young platelets, right? That's consistent with a peripheral destructive process. What's happening is your platelets in the periphery are being destroyed. The bone marrow is in overdrive, making good new platelets. They're being pushed out of the marrow prematurely. So what's floating around in the periphery is these big, fat, chunky, juicy, really sticky platelets. They work really well, which is oftentimes why these kids don't present to us until they have platelet counts single digits, 10, 11, 12, okay, because what they have works very well. A bone marrow is not necessary to make this diagnosis, unless your diagnosis is in question. I've had at least one kid over the years who looked like ITP, wasn't responding at all to IVIG that we were giving. And sure enough, over several days' time, his other counts started to fall. We did a bone marrow on him. He turned out to have aplastic anemia. So if the kid is not behaving the way they should, based on your interventions, you should start thinking of something else. What do we do with ITP? Do we have to treat it? No, we don't have to treat all kids. I think most pediatric hematologists would agree that we treat patients who are in single digits, at least when they're new. I have plenty of chronic ITP kids who hang around in the single digits, and their parents prefer them not to be treated. If they're an acute ITP patient in single digits, we will usually treat them. If they have less than 20,000 platelets with non-life-threatening bleeding, nosebleed that won't stop, menstrual bleeding that won't stop, we will treat those kids. Or sometimes we try very hard to just monitor these kids, and if they are trending in the wrong direction, if we find them and they're 25,000 and we say, ooh, I'd love to not treat that, and then we have them come back to clinic and they're 18, and then they come back again and they're 12, then you kind of just feel like you're headed the wrong way, and we may just treat those kids to try to bump them back in the other direction. The goal is not to normalize the platelet count in these kids, okay? They don't need to have a normal platelet count. What we need is to get them out of a danger zone, okay, to prevent life-threatening bleeding. As rare as spontaneous intracranial hemorrhage is for these kids, we do know that it happens more often when they are less than 10,000. So we just need for them to get into a safer place. What do we use? So most often we use IVIG, 800 per kilo one time. We may need to give a gram per kilo, may need to give a gram per kilo twice, but there's good data to suggest that this dose is sufficient. If you have an Rh positive patient, you can give Winro, which is anti-Big D. Not using this one as often anymore. There's actually a black box warning from the FDA on this now, because in some older patients, they have experienced hyperhemolysis. They have incurred acute kidney injury, and there have been deaths reported in older patients due to this. It used to be super convenient. It was slow IV push. You could do it as an outpatient and send these patients home, whereas the IVIG is a several-hour infusion. Now the package insert says you should monitor them overnight, check electrolytes, this, that, and the other thing in the morning, so it's become a whole lot less convenient than it used to be. Steroids are still good. They're old, they're cheap, they work. We will use them alone or in combination with IVIG at times. As always, the side effect profile is the rate-limiting problem here, because you can't just give someone a 4 or 5 day pulse of steroids for acute ITP and expect to stop the steroids and have a good platelet count. That platelet count is going to drop right back down. It's very rare to find an ITP patient who doesn't respond to steroids. The problem is getting them off, because if you don't wean them off very slowly, they're going to drop on you again. We don't use platelets, right? Everybody's platelets are similar enough that if you try to transfuse these kids, they're just going to destroy what you give, unless the patient is experiencing life-threatening bleeding, as in, again, intracranial hemorrhage, in which case, of course, we're pouring in pretty much all of these things at the same time. What about chronic ITP? So this is immune-mediated thrombocytopenia that lasts for, I'm going to say, greater than 6 to 12 months. I think gradually we're moving out more to a duration of 12 months. I think we're finding, based on experience, that there are a lot of kids. So it used to be chronic ITP was if you had it over than 6 months. Now we're going out to more like 12. I think there are a lot of people who hang out in that 6 to 12 month range, and then they spontaneously remit. 20% or so of acute immune thrombocytopenia will persist. Still, though, even if they've had chronic ITP for as many as 3 to 5 years, sometimes this will just shut off as quickly as it started without any real understanding behind it. The girls are a little more likely to develop acute ITP than boys. Adolescents and infants tend to do this a little more frequently than children in the other age groups. And these platelet counts tend to run not as low. The goal of the intervention for these kids is to maintain good quality of life, have them doing what they want to do. Okay, these are the kids who hang around, 30 to 80,000. And if they hang around above 50 all the time, you don't have to do anything. If you've got a kid who likes to play competitive soccer and they respond to brief steroid pulses or they respond to IVIG, and you only have to give it every 8 to 12 weeks to bump them back up above 50,000, that's workable, and that's something that's a decent long-term solution for that kid. I do screen for autoimmune disease in patients with chronic ITP once per year. Just get kind of a basic set of labs. You have to watch out that chronic ITP is not them trying to present with some other larger autoimmune phenomenon. So I will do that once per year, particularly in the teenage girls. You have to watch out for that. Again, these kids, treatment may not be necessary at all. Some of them get intermittent Winrow, IVIG, 4 or 5 day steroid pulse every now and then. Rituximab, right, which is an anti-CD20 monoclonal antibody. Some people have had that with varying success, kind of an immune system reset. You're trying to deplete their mature B cells that are creating that immune globulin. Splenectomy certainly works in a subset of patients. And new on the scene and exciting and very effective and even FDA approved for children is the thrombopoietin agonists, which are nice and even administered orally, which is great. And what about other thrombocytopenia? So acute ITP often falls into a pretty severe category. Like I said, we'll find these kids 2,000, 8,000, 12,000. You may at times, with all the CBCs that you order on a regular basis, may uncover something more mild. 100,000, 120,000, maybe something 50, 60, 70,000, okay? You just need to help sort out, is it a decreased production problem? Is it a destruction problem? Sometimes you can't tell for sure. Is it drug-related? Do you have a kid on some, for instance, an anti-epileptic, antidepressant that can do that? Is it a congenital thrombocytopenia? How low is the number? What's the other clinical story? Is it a post-viral phenomenon? Goodness knows, we see so many CBC abnormalities during and after childhood illnesses. Do they have other more global autoimmune disease that you're uncovering? DIC, of course, in the proper clinical context, you're not going to pick that up on someone who wanders into your office, but certainly in an ICU setting, we'll see that because it's a consumptive problem, right? Do they have splenomegaly and portal hypertension? Again, depending on where you practice. When I was here, we had a fair amount of liver transplant patients who had portal hypertension, so I saw that quite a bit. Where I am now, we don't do liver transplants. I don't ever see that anymore. So it depends on, kind of what your practice pattern is. Okay, moving on. So how about back to the newborn nursery? To evaluate a term newborn, uncomplicated pregnancy, G3P2, healthy mother, exam positive for facial bruising, petechiae about this baby's face, trunk, and legs. Platelets are 8,000. Hemoglobin is 13, white count 12,000 with a normal differential. Mother CBC is normal. What is the most likely diagnosis for this baby? Probably neonatal alloimmune thrombocytopenia, right? Which you'll definitely see if you hang around in the nursery for periods of time. So what is this phenomenon? So usually this is in, so neonatal thrombocytopenia is unusual in healthy babies. Usually you see the significant thrombocytopenias in more ill babies. However, this NAT you can see in just about anybody. So think about sepsis with or without DIC. Do you have a baby with a large hemangioma where they're consuming some platelets? Birth asphyxia can definitely do it, meconium, thrombosis. Babies just don't have that much blood volume, so if they have a significant thrombus, that can actually produce a consumptive phenomenon and a lowered platelet count. Certainly leukemia we see in neonates, again, not common, but anything's possible. Neonatal alloimmune thrombocytopenia. So this is, right, the platelet equivalent of ABO incompatibility, right? This is due to IgG antibodies that are directed against this human platelet antigen 1A, and the mother expresses only HPA 1B on her platelets, okay? So somehow Baby's platelets look like dad's. Mom has IgG that floats over and destroys that baby's platelets. This occurs not uncommonly, 1 in 1,000 to 5,000 births. The first pregnancy can be affected, okay? So if you have a first-time mom, doesn't mean this can't happen. But subsequent pregnancies, for sure, you may have a more severely affected infant. These are patients who definitely need outpatient follow-up with a hematologist after. We will arrange to have mom and dad tested to confirm this diagnosis. You have to watch out for intracranial hemorrhage in these babies, 10 to 20% of cases, quarter to a half of which may actually happen before the baby is born. Ideally, you have maternal platelets available. That is not a practical solution in a lot of cases. IVIG is what is given more commonly. If you need to give platelets urgently and moms are not available, you can certainly transfuse with random donor platelets. The goal is to keep platelets greater than 30,000. If you have a term baby, 50,000. If you have a preterm baby, and these babies will be followed with serial head ultrasounds just to make sure that there's no intracranial hemorrhage. And what about a congenital thrombocytopenia that you've uncovered? These are very unusual. In the appropriate clinical context, you should be considering them a congenital infant leukemia, Wiskott-Aldrich maybe, or an X-linked thrombocytopenia. If you have a little boy, I'll tell you a story about that. Fanconi maybe, thrombocytopenia, absent radius. That one likes to show up on your tests. I don't think I've ever actually seen it. And again, a rare congenital amegakaryocytic thrombocytopenia. I was going to bring up this kid I saw actually just recently, sort of reinforces the notion of looking at a smear. He's a 6 or 8 month old, I think, little baby, covered in petechiae. He showed up at an outside emergency room with a platelet count of 14. They repeated it and it was 15. Kid was also covered in eczema, and mom said, oh, he was born with eczema. So he came to our place and I told the ER, I said, no, don't poke him again. We already had 2 values. I'll check him again in the morning. And I wasn't going to treat him for 14 or 15,000, figuring this kid probably had ITP, but I thought, what the heck, is this a new Wiskott-Aldrich who's dropped on my door? Which would be weird because we had one like a month ago. So sure enough, the next day, this kid was 24,000. So I didn't do anything, and I looked at the smear, and I thought, ooh, I want to find some really tiny platelets. And he didn't have many on the smear. We looked and looked and looked, but they were either normal in size or actually a little bit big. So I think my diagnosis of possible Wiskott-Aldrich or X-linked thrombocytopenia was going out the door. Sure enough, I didn't have to treat that kid. Came back to clinic, and he was 63,000. Saw him a couple of days ago, and he was 193,000. So that I haven't seen in an infant, I will tell you, and I sort of wonder if the way he was covered in petechiae, I wonder if before he went to that first emergency room, he was lower than 14,000. I think he was probably in the single digits somewhere, and we caught him on the way up. But anyhow, sort of reinforces, right? We actually do look for things on the smear, and it does really sort of change your thought process, so. What about qualitative platelet defects, right? So people who have a normal number of platelets, but they just don't work well. So you have congenital qualitative platelet issues. Bernard-Soulier, this is absence of the glycoprotein 1B receptor on your platelets. Glanzmann's thrombocythemia is absence of glycoprotein 2B3A. Bernard-Soulier, this one will look a lot like, they'll behave a little bit like a von Willebrand's. Maybe a storage pool disorder, an alpha granule disorder, delta granule disorder, things of that nature. Things we have to diagnose with fancy things like electron microscopy. Or do you have an acquired qualitative platelet defect, for instance, from medication use, maybe uremia, right? Proper clinical context. If you are at a place where you have a large nephrology area where you have a lot of kids on dialysis, you do a lot of kidney transplant, you may see a lot of kids who run around with BUNs 50, 60, 70, 80 all the time in between their rounds of dialysis. They may have some platelet dysfunction as a result of that. Okay, moving on. 15-month-old, previously healthy boy, walking around for 4 months, started limping after he learned how to jump off the couch. He now completely refuses to bear weight, and on exam, you see a somewhat fussy infant, no fever, has a little bit of warmth and swelling over his left knee. Which statement about a patient with hemophilia is false? Oh, this one. I usually get people all over the map with this one. Okay, so B and E are both false, right? So the PT should be normal, right? That is not reflective of factor 8 or 9 deficiency. It's your PTT that you'll see abnormal with a patient with factor 8 or 9 deficiency. So the PTT is prolonged, but if you add control plasma, so that you're adding the factor that the patient is missing, and you rerun that PTT, that's called a mixing study, right? If you rerun a PTT with control plasma, it's going to correct. That's diagnostic. It tells you what's missing. It is X-linked. Family disorder may be negative for bleeding disorders. That is true. Plasma is not the preferred treatment, okay? And we'll talk a little bit about that. So what about the hemophilias? So they are unusual. Combined incidence of 1 in 5,000 live births. People, it's important when you're thinking about a bleeding disorder, your mind shouldn't go here first. You really should be thinking a little more of von Willebrand's disease. We'll talk a little bit about that. That occurs in more like 1 in every possibly 100 people, so quite a bit more common. So A is more common. 2/3 are severe. They're a little bit more difficult to deal with. More than half of the B, hemophilia B patients, are mild to moderate. They tend to be a little easier to deal with, less likely to develop inhibitors to their treatment. So the hemophilia A boys can be quite a bit more challenging. Categorize them as mild, moderate, and severe, right, depending on how low their factor values are. Mild patients that have greater than 5% factor activity, they can go many, many years before being diagnosed. It's striking how low you can be on a percent factor value in your plasma and be hemostatic. There are kids running around 10, 15, 20% factor 8 or 9 levels, and you never know any differently. Okay, so this, the genetic defect here lives on the long arm of the X chromosome. Genetic testing, certainly possible, but 1/3 of them have spontaneous mutations, okay, where they have no other affected family members. How do they present? Well, again, depends on the severity. Even severe patients are often not diagnosed until they're crawling or walking. You know, if you're a boy and you have 1% factor 8 or 9, and you're just an infant who kind of lays around all day, you're not going to notice that. Sometimes you might hear something like when the parents will sort of grab the ankles to lift their bottom up during a diaper change or something, they'll notice that they see some bruising that way. Maybe if they sit in their swing or their high chair, you'll hear them say, oh yeah, you know what, I've seen some bruises on the back of their calves before. Didn't realize that was from. So sometimes even just pressure points, you know, can cause some bruising in these kids. Typically, you'll see excessive bruising. Sometimes they will present with hemarthrosis. They may have some oral bleeding, whether with tooth loss, maybe some post-surgical bleeding. Immediate newborn bleeding, don't count on bleeding after a circumcision in all these babies because they don't all do it. Intracranial hemorrhage, thankfully, is rare but not impossible. Taking care of some of those kids. Actually here over the years who have developed chronic intractable seizure disorder because of an intracranial hemorrhage that they had prior to their diagnosis of hemophilia, came here for epilepsy surgery. So it does happen. How do you make this diagnosis? It's pretty simple. The PTT is prolonged, your PT is normal. You have a PTT that corrects with the addition of control plasma, and you'll have low plasma 8 or 9, okay? Needs to be on a fresh specimen. The longer these specimens sit in a lab, like if you draw somebody on a Friday and it doesn't get run until Monday morning, you should take that with a grain of salt. Make sure you repeat that value before you label them with that diagnosis. How do we manage these kids? Well, mild kids, they may do well with just DDAVP or some intranasal stimate to bump up their factor 8 levels in select situations. Moderate, this is very general for your purposes. Moderate, they may require treatment only with trauma, maybe prophylactically before they do things like play soccer, things of that nature. Severe patients, prophylaxis is indicated for these kids at a very early age before they begin bleeding and before they potentially develop what's called a target joint and start to develop chronic joint damage. Definitely to be avoided. The face of older boys with hemophilia looks very different today than it did many, many years ago when these boys were severely debilitated as adults because of terrible, terrible chronic joint disease. For all replacement for these kids who need factor infusions, recombinant products are the standard of care, not plasma that has a bunch of stuff in it that they don't need, or any plasma-derived product, okay? These kids should all be on recombinant products that are pure, and you don't have to worry about any viral transmission. Replacement guidelines, very specific to the clinical situation. Rarely do we need to get kids up to 100% factor activity for most things that happen to these kids. You know, a fall, a surgery, this, that, or the other thing. If you can get them to 50, 60% factor activity, they're hemostatic, they're fine. Most children do self-infused prophylaxis at home. They either do it themselves or they have a parent who does it. These are extremely bright and very self-sufficient families, generally speaking. Comprehensive lifelong care for sure is necessary. These kids are cared for at comprehensive hemophilia centers where they have all of the resources that they need. Okay, how about a teenage girl? Severe, I wouldn't say severe anemia, I would say moderate anemia, 7.5, we'll say. Menorrhagia for several years. Lifelong history of easy bruising and frequent epistaxis. Her father and paternal uncle also have a history of easy bruising. Her platelet count and PT are normal. Her PTT is prolonged. Which of the following is true? Okay, good. She may very well have von Willebrand's, right? I would say C is the best answer. Most girls who are carriers of hemophilia, generally speaking, they have a normal PTT and very often do not have any bleeding symptoms, okay, even if they have 40, 50, 60% factor VIII, okay? Type 2 von Willebrand's would not be the most common. You'll find, I think we talk about that, type 1 is actually the most common, okay? Again, compared to hemophilia, this is a very common bleeding disorder. Happens in 1 to 2% of the population, and no doubt about it, there are lots of people with mild von Willebrand's disease wandering around who don't even know that they have it. People who are, oh, I'm an easy bruiser. Oh, I always get nosebleeds. Oh, my periods have always been like this. Those very well may be some undiagnosed von Willebrand's people. Many, many responsible mutations, too many to know about, too many to test for. Great variability between patients, even in the same family. You can have two affected people, two or more, and they will not all bleed the same, even if they have similar lab values, which is interesting. It's usually autosomal dominant, okay, not always, excepting type 3, which is a very severe disease that is autosomal recessive. And you have so little, almost undetectable von Willebrand's factor in the plasma that all of the factor VIII is also depleted, right? So you just have to remember what that relationship is, right? Factor VIII is very small. It is easily auto-degraded in our plasma. It pals around with von Willebrand's antigen in the plasma. The von Willebrand's antigen protects it, okay? So the lower your von Willebrand's antigen goes, the more susceptible and unsheltered your factor VIII is, and it too will go down, okay? Type 3 von Willebrand's is how you get a girl who looks for all the world like she has hemophilia A, because she will have undetectable von Willebrand's antigen, she will have almost undetectable factor VIII, okay? It's a very bad disease. Thankfully, we don't see it very often. How do these people present? Any number of ways: bruising, epistaxis, oral bleeding, bleeding after wisdom teeth come out, menorrhagia, petechiae, you name it. It's kind of all over the map. Diagnosis is very tough. There are regular fluctuations in von Willebrand's factor antigen. There are diurnal variations. There are variations with where you are in your menstrual cycle. It is an acute phase reactant that goes up in times of stress, so it's very difficult to draw little kids, for instance. Sometimes, depending on your index of suspicion, you have to test them more than one time. I will say, too, because I can't remember if I say anything about it, it's really important when you take a good history. I saw a girl just yesterday in clinic, had seen a GYN for prolonged menstrual bleeding, but not heavy bleeding. Okay, she's been bleeding a little bit daily since, hard to believe, but it's true, November of last year. Never became anemic, so she wasn't bleeding all that much. GYN had tested a little bit for von Willebrand's, and she had a von Willebrand's antigen that came back at 63%. That turned up a little bit low in their lab, not clinically significant. Anyhow, this girl, over her lifetime, she's had 10 teeth actively extracted because her deciduous teeth weren't falling out on their own, never had any bleeding issues. Okay, that's a person who doesn't have von Willebrand's disease. If you have 8 or 10 teeth yanked out in your lifetime, the mouth is a very bloody place, okay? We would have known when she was a toddler that she had von Willebrand's disease. So sometimes if you just ask the right questions, you'll get to the right spot. So what do we call these patients? Really, do we call them von Willebrand's disease, or do we call them they have low von Willebrand factor antigen? Because technically speaking, you're supposed to have von Willebrand's factor antigen levels below 40% to be diagnostic of this disease, and a lot of people really don't get that low. They're somewhere between 40 and 60, so they are low in your lab, and they do have some clinical symptomatology. So you really should get von Willebrand factor antigen. That is your quantitative test, right? You should get ristocetin cofactor activity. That is your qualitative test. Factor VIII level, platelet function screen, okay? This is primary hemostasis, okay? This is not secondary hemostasis where all of your factor cascade happens. This is primary hemostasis where you need to be able to form a platelet plug, okay? You have a non-intact endothelium. All your platelets are swimming past. They need to be able to latch onto that subendothelial von Willebrand's antigen to form a platelet plug. Then your platelet surface is activated. Then all your secondary hemostasis happens. So if the body can't do this, everything downstream also doesn't work, okay? That's why the bleeding that these kids do looks a little different than the bleeding that the factor deficient kids do. Again, less than 40% activity is really diagnostic. It's pretty unusual to see kids this low. Most kids are type 1. That's 70 to 80% of patients. Type 1 is low. That is a quantitative problem, okay? They simply don't have enough. The type 2s are a qualitative defect. They have enough, but it doesn't work well. So they'll have a normal von Willebrand's antigen, low ristocetin cofactor, okay? Treatment depends on the type of disease and severity. Type 1 kids, again, they can often get by with some intranasal stimate to just boost their numbers a little bit. Sometimes if you have a girl who's only experiencing menorrhagia, you can put her on low-dose oral contraceptives. That'll be enough to boost up the estrogen levels, which in turn boosts up their von Willebrand's and factor VIII levels. Some of them can get by with Amicar, which is an antifibrinolytic. They can take that by mouth. I have kids who, let's say, have a tooth pulled, need to have a tooth pulled, tooth falls out. They can actually use Amicar topically, soak it in a cotton ball, and just stick it in the socket, and that will do the trick. Type 2, there are several type 2s, 4 of them, A, B, M, and N. Sometimes they can get by with DDAVP. Sometimes they need factor infusions. It depends on what type 2 they have. Again, depending on the severity, maybe some oral treatment with Amicar. And this is exciting too. There's actually a recombinant von Willebrand's infusion that is brand new on the market, so that's exciting. It's been in Europe for a long time. The type 3s, again, we talked about how terrible these patients are, and they are getting still plasma-derived 8 and von Willebrand factor infusions, maybe OCPs, and again, just like a hemophilia patient, these patients may require regular infusions. I think this will be beyond the scope, probably, of what they would ask you about. Rarer coagulopathies, okay, you can be deficient in any factor. Any one of them you can make not enough. 2, 5, 7, 10, or 11. One that you should really sear in your brain is factor 13 deficiency. This one likes to show up on tests. It's a classic presentation of bleeding and bleeding and bleeding and bleeding and bleeding that doesn't stop from the umbilical stump. This is the very last cross-linking factor in the clotting cascade. The PT and PTT are normal. Okay, so this one fools people quite a bit, but the classic presentation is bleeding from the umbilical stump. And if you give them some plasma, it stops. You're gonna have a hypo or a dys or an afibrinogenemia. These are pretty rare. They are out there. And this occasionally comes up. Factor XII deficiency actually does cause a prolonged PTT, sometimes a very drastically prolonged PTT. Sometimes the lab can't even tell you how many seconds it is because it stops counting, but it's not associated with clinical bleeding. It actually, in its pure super deficient form, is a thrombosis risk. In fact, the gentleman after whom this factor is named died of a pulmonary embolism. So sometimes people will uncover that one accidentally. We actually had a kid with ALL, a boy. He had completed all of his treatment, and he was going for a procedure with the surgeon for some such thing, and had a PT and a PTT drawn, and he had factor XII deficiency the whole time we knew him, and nobody had ever known about it. Okay, what do we have now? 5-year-old boy, acute onset of high fever, 105. He's got a little low blood pressure, severe headache, and neck stiffness. He develops oozing from his IV site and has some dusky discoloration of both lower extremities. Which lab result is not consistent with DIC? This one usually gets, I usually get some D's and some E's on this one. I don't mean for it to be tricky. The leukocytosis in the CSF, that's your kicker, right? This kid has meningitis. So in my mind, that sort of supports the diagnosis of DIC, not to mention the fact that you don't have DIC and have an elevated fibrinogen. That doesn't exist, right? DIC is a consumptive process where your platelets go down, your fibrinogen goes down, all your clotting factors go down, which is why your PT and your PTT go up, okay? It's a clinical diagnosis of bleeding. Sometimes it's horrible. You have bleeding, thrombosis at the same time. If left untreated, these patients will end up with progressive organ dysfunction and organ failure. It's an underlying tissue destructive process. Again, it's a very consumptive process. All of your coagulation factors and platelets are being consumed. Typically, you'll see a prolonged, sometimes dramatic PT and PTT. You should see thrombocytopenia, low fibrinogen, very elevated D dimers. That's your indication that there is intravascular thrombosis happening. Many causes. This is certainly not an exhaustive list. Infection certainly is the most common thing that I see taking care of oncology patients. If you are at let's say a large trauma center, a large burn, pediatric burn unit, you'll see this a lot. Certainly hypoperfusion and reperfusion injuries, we can see this as well. The treatment, it simply is not going to get better unless you treat the underlying cause. Okay, so this is one of those things, right? You're doing everything all at the same time. Blood pressure support, you're pouring in plasma, cryo, trying to fix those numbers. Cryoprecipitate is part of plasma that is just very rich in fibrinogen. If you give plasma alone, you're giving some fibrinogen. But we give cryo if what you're really trying to do is boost the fibrinogen. And again, treat the underlying cause or it's not going to get better. Okay, 11-year-old boy with acute lymphoblastic leukemia. He's been admitted with fever and a positive blood culture. He develops swelling of his arm, happens to be on the same side as his central line. You smartly grab a Doppler ultrasound, which confirms an occlusive thrombus in his left axillary vein. Which of the following might have contributed to his thrombosis? Okay, the majority gets it. Definitely all of the above have contributed to this kid's current situation. All 4 of those are known to be pro-thrombotic conditions, okay? So what do we say a little bit about thrombophilia? Technically, it's a susceptibility to thrombosis, whether it's congenital or acquired, is usually the way we sort of compartmentalize them. Genetic susceptibilities, the more common ones that we see, Factor V Leiden mutation, prothrombin mutation, by far the most common. Factor V Leiden, common in Northern European folks, may be present in as many as 5 to, in some places, 8% of the population can be heterozygous for Factor V Leiden. Homozygosity for MTHFR, I put a question mark there because the significance with normal homocysteine levels is extremely low. It is of 0 clinical significance as an isolated finding. Typically, this is found in conjunction with other things that you test for. A very high proportion of the population is heterozygous for MTHFR, and it has 0 meaning. Fewer, but still a significant number, are homozygous, and it doesn't mean anything outside of the adult arena where it is associated with cardiac atherosclerotic disease. Less common genetic susceptibilities, we see protein S deficiency, protein C, maybe antithrombin 3 deficiency. Again, pretty unusual. I've seen 1 or 2 kids with something severe on this list in several years. Acquired susceptibility by far is more common, as in the little boy we just talked about. If you have a central line, right, that's a foreign body, automatically a thrombosis risk. Oral contraceptive use, for sure, is a risk factor. Prolonged immobility, which even, it's pretty unusual now for us to see kids who are immobile for a prolonged period of time, but it's still there. Asparaginase therapy, for sure, that wreaks havoc on the coagulation system, and they are prothrombotic. Antiphospholipid antibodies that are permanent, not transient, okay, as in antiphospholipid antibody syndrome. That is a thrombophilia risk factor, and acute or even chronic inflammation. So we see, kids with inflammatory bowel disease, for instance, who are having an exacerbation, high inflammatory markers, get a PICC line put in, have to come into the hospital, whether it's, antibiotics, TPN, some such thing. Very often we can see those kids clot off their PICC line because they are in a very high inflammatory state, put a foreign body in their blood vessel, and they're a setup for a clot. Well, how do we manage these patients? Not surprisingly, situation dependent, right? Thrombolysis, very, very rarely indicated for venous thrombosis. Unless we catch it really early, and then we can do thrombolysis. It's typically reserved for arterial thrombosis in children. Immediate anticoagulation, duration TBD, 3 to 6 months, depending on the clinical situation. And in the case of our friend here with his central line, should be removed unless you're in a situation where you absolutely can't remove the central line. It should come out. A hypercoagulable workup is not indicated for a lot of patients, actually. Certainly the acute phase is not the time to do it because they have an active clot that is consuming a lot of things. So you're going to get a lot of wacky values that you're just going to have to repeat. And knowing those answers is not going to change your management anyway. And insurance companies really, really don't like it when you test for some of these things as an inpatient. So it's just better for everybody if you wait and do the testing another time. Who needs to be screened for thrombosis? This is always a hot topic. Do you screen adolescents prior to oral contraceptive use? Well, the guideline, it's suggested only if there is a pertinent family history, meaning someone in the family who has had a significant thrombosis event, not limited to a pulmonary embolism. What do you do with those results? It's not clear. We get a lot of these consults. For a teenager who was found to have Factor V Leiden, and someone has said, no way I'm giving you birth control pills, go see a hematologist. So, we have a long discussion about it, talk about lifestyle choices. It's not the same answer for every person. If I can detect a lot of women in a family who have Factor V Leiden, but they've never had thrombosis issues, several pregnancies, this, that, or the other thing, and never had any issues, I think that's probably a girl who can safely go on birth control pills, realizing nothing that we do is without risk. If you look at a package insert for any birth control pill, even if you have normal blood clotting is a risk. So it's tough. We just have to have a thorough discussion with those patients. And I think that's it. Thanks.